Dr. Emma Searle, Consultant Haematologist and Deputy Medical Director at Clinical Research Facility in the Christie Hospital. So Emma will update us on a novel first-in-class drug in combination, and Emma was supported by funding from UKMS and Menarini Stemline.
Thank you, and thanks very much to UKMS and to Menarini for facilitating funding for my travel to ASH to be able to present this data. It's a commercially sponsored study, but very much a UK collaborative effort, and I'll talk you through the data that I presented now. So inabrodib's a first-in-class oral agent which targets the bromodomain of P300CBP, which are epigenetic co-translational regulators of gene expression in the cell. The inhibition of these two proteins results in downregulation of key myeloma oncogenic drivers such as IRF4 and MYC, and this strong rationale for activity as monotherapy and exquisite synergy with IMiDs has been previously demonstrated in my colleague Professor Tim Somerville's lab in work that was published in Cancer Cell last year. I previously presented the monotherapy data a couple of years ago at ASH, which showed that there is activity with a modest overall response rate of around 25%. And the data that I presented at the most recent ASH was the combination study with pomalidomide. So here's the study design, standard for a study of this type. We looked at different doses of the combination of inabrodib and pomalidomide, ranging from 3 milligrams of pomalidomide to 25 milligrams of inabrodib, through to 35 milligrams of inabrodib and 4 milligrams of pomalidomide. The interrupted dosing schedule was because of monotherapy data, which showed that we see some thrombocytopenia, which the interrupted dosing schedule allows for recovery of in the weeks between doses. So the primary objective was the safety profile and identification of a dose to take forward to the randomized expansion cohorts, and there were secondary objectives that concern themselves with early efficacy signals and exploratory objectives looking at PD biomarker profiling. Here's the pharmacokinetic data. This isn't affected by the addition of pomalidomide. There are dose proportional linear pharmacokinetics. The half-life is 4 to 6 hours, which supports the twice daily dosing. And here's our patient population, which is fairly typical of a phase 1 study in this space. Patients ranged between 41 and 82 years. Most were white, most were men, and most had an ECOG of 1 or 2. This study actually originated as an advanced hematological malignancy study, so that we treated lymphoma, AML, high-risk MDS, myeloma. So there was no kind of myeloma-specific imaging in the early days of this study to assess for extramedullary disease. So this is probably under-reported in this table. But you can see that the patients did have a high disease burden, with over 40% of patients having greater than 50% marrow involvement and a third having elevated LDH. The cytogenetic data is in progress. They were also very heavily pre-treated group of patients with a median of 5 prior lines of treatment. 45% of patients had undergone a transplant. All of them were triple class exposed, and the majority were actually pomalidomide refractory, but that didn't prohibit entry into this study. About a third had had a prior BCMA in the main, bispecific T-cell engaging antibody, or another BCMA-targeted treatment. So the median follow-up, this is a really busy slide, so apologies for that, but the median follow-up at the point of the data cut-off prior to ASH was 14.5 months. At that time, 23% of the patients were ongoing on treatment, and the most recent common reason for treatment discontinuation was disease progression. The median duration of treatment was just over 6 months, with a range of 1 month through to 21 months, and 20% of patients overall required an inabrodib dose reduction, though this was only 11% in the highest dosing group. In total, 35 patients were evaluable for response assessment, with 2 having discontinued due to patient decision and 3 not having measurable disease at the outset. Again, sort of a testament back to this not being a myeloma-specific study in the early days. Overall, the combination was well tolerated. There don't appear to be differences in the safety profile between the different dosing levels. Most common treatment-emergent adverse events were mild to moderate cytopenias and fatigue, which generally didn't impact compliance, with only 5 patients discontinuing due to an AE. As already mentioned, the thrombocytopenia was predicted, and 14 patients had grade 3 or higher platelet decreases, which was manageable in the main, and there were very few bleeding events, which were mostly grade 1. Grade 3 or higher neutropenia was also common in this very heavily pretreated group, but febrile neutropenia was rare, and the neutropenia can usually be successfully managed with GCSF. There was a single fatal adverse event of myocardial infarction that was not considered to be related to the study treatment. And overall, although these are limited numbers of patients, the tolerability profile appears comparable to the published data with pomalidomide and dexamethasone, and there don't appear to have been any safety signals identified when compared to the monotherapy data. So here's a swimmer's plot and bar chart showing the 3 cohorts separately. The median treatment durations marked on the swimmer plot, and you can see that some patients achieved durable responses and remained on treatments for over 18 months. Overall, the overall response rate was 49%, with a median duration of response of 6.3 months, and 63% of patients had a response lasting 6 months or more. And these figures, the light green signifies PR, dark green VGPR, and blue stringent CR. And looking at the bar charts, you can see that the rate of response, PR or better, improved to 75% and deepened in the highest dosing cohort of 35 milligrams INO and 4 milligrams of POM. The median duration of response in this highest dosing group was 9.7 months. Of the 8 patients who experienced disease progression on pomalidomide immediately before they entered the study, as indicated by the red bars on the swimmer's plot, 4 achieved a response of PR or better, and 1 achieved an MR. Out of the 12 pomalidomide naive patients, 2 achieved an SCR, and both of these were MRD negative. This slide shows a few brief case histories and the paraprotein levels for 3 patients receiving NOPD as exemplars. The first patient had 3 prior lines of retreatment and was refractory to pom and dex as the last line of treatment, and this subject achieved a VGPR and remains on treatment after nearly 20 months. The second patient, who was a patient of mine, was POM naive despite having received 7 prior lines, and that was because of concerns about the tolerability of IMiDs in their previous lines. And they initially received inabrodib as monotherapy, but when we saw that they started to progress, pomalidomide and dexamethasone was added in, and they achieved an MRD negative SCR and remain on trial after 19 months. The third patient had 6 prior lines, including Belmaf and Elran, but achieved a VGPR on NOPD before progressing after 11 months on study. So in conclusion, inabrodib in combination with pomalidomide and dexamethasone has a manageable safety profile, favorable pharmacokinetics and promising efficacy in heavily pretreated myeloma patients. The highest efficacy was seen at the highest dose of 35 milligrams twice daily, with 4 milligrams of pomalidomide and dexamethasone given in standard weekly doses, and there was a 75% overall response rate and activity seen across all dosing levels. And the 2 of the pomalidomide naive patients achieved an MRD negative SCR, and efficacy was observed in pomalidomide refractory and BCMA T-cell engager refractory patients. There were no safety signals seen across the 3 dosing cohorts. Thrombocytopenia was the most frequent treatment-emergent adverse events, but was generally manageable, as was neutropenia. A randomized expansion is currently recruiting, and I'd like to thank all of the patients who participated in this study and my colleagues at other UK sites who've contributed to recruiting and looking after the patients in this trial. As this study is heading into an expansion phase, more sites are coming on board, so I'd encourage all of you to reach out if you have patients that might benefit from this study. Thank you.
Thank you very much, Emma. It's a fantastic talk, and always encouraging to hear about these new treatments coming through that can be delivered in heavily pretreated patients. So any questions for Emma?
Hi, Emma. Thank you. Very nice talk. Nice data. I guess a general question, I mean, it's the relapse refractory space very busy.
It is.
And there's so many pomalidomide regimens already in trials, some registration studies. Where would you see inoperative fitting in? Would this be the post-BCMA exposed patients or a particular cohort, like the MYC aberrations?
Yeah, so I think, well, you're going to get different answers potentially in different bits of the world, aren't you? But also, I see that there are different groups of patients that might benefit from this approach. I think it's really tolerable treatments, and I think I would certainly put patients on NOPD that I might have reservations about using a bispecific in, and there'll be some patients that will just never sign up for a bispecific because of the rigmarole of coming to and fro for treatment and the management of the CRS initially. So for patients who just want to come to clinic once a month, pick up their pills and wave goodbye to us for another month, then this might be a great option. But I also think you're right, completely, we don't know. I do put patients who are post T-cell engager into this study. We struggle for good options for them, don't we?
Thank you.
Don't think there's any other questions, so thank you, Emma. Thank you.